Okay. All right, thank you everyone for coming. Today's talk will be on Lyme disease. So this is a very popular topic, and if anybody wants to say anything, please feel free to speak up. And I want to thank Dr. Pathakar for coming today from Infectious Disease. So Lyme disease, that's a picture of Richard Nixon and Sammy Davis Jr. from 1973. That's when Doug was what year, like elementary school in that year, right? No? Elementary school. I'm just kidding. So it was around that time. Hey, Bill. Good morning.
Good morning. Sorry.
It was around that time that Lyme disease started, and it started in. If anybody wants to hear the history, you can see it all on YouTube. Type CDC Grand Rounds, and the Grand Rounds that was a couple months ago in Atlanta is on YouTube. And actually, I listened to it on the way here on my iPhone while I was driving. So it's actually a very good lecture. And Alan Steer went over the history of Lyme disease and gave a review. And he was the first article in 1977. And how it started was interesting. That it started with a couple moms in Lyme, Connecticut, called the CDC, and they said the children on our block all have juvenile rheumatoid arthritis, and even some of the dads have juvenile rheumatoid arthritis. In our community, there's like on every block there's like a couple kids with JRA. This is weird. So the CDC started looking into this, and they found that it was always in the summertime. So that's how it all got started. And then the initial article was in 1977. They didn't know what it was. It was just arthritis. And these kids were getting it, and some adults were getting it. So that's when they just said it's Lyme arthritis, because they had all these people in Lyme, Connecticut who had it. So, where total Lyme cases, there are not that many cases, but it's got to be underreported. Because I know, like, primary care physicians, they don't report Lyme disease. I don't report it when I diagnose it, so it's probably way underreported. But it's mostly, 90% is in our area, Maryland, Delaware, New Jersey, New York, and Connecticut, and also Wisconsin and Minnesota. So that's 90% of Lyme disease. And I think, and McCool, you interrupt me if I say anything wrong, I think a lot of the people who get it that are not from this area were visiting these states, got it, and then went home and were diagnosed with it. So when they report it to the CDC, it's where you live that they report it from. So if you go to Harford County and you hunt deer, and then you go back home to California and you're diagnosed with Lyme disease, it's where you live. Your zip code is where they report it. So the disease comes from a spirochete. So I think that's the main thing. This creepy coil-like thing, like snaking around your body, just gives me the creeps. And it's the same type of organism like in syphilis. And it's given by ticks. So this is the deer tick, which is called Ixodes scapularis, which is in our area. And they're all different types. So this is in the larval stage, it's tiny, and then in the nymph stage, it's about 2 or 3 millimeters. And these are the ones that infect humans, because the big ones, the adults, we find, but the tiny ones we don't find. They're just too small, and we don't realize we have them. And the other interest. So here's a sesame seed, and these are what the adults look like, and the nymphs are like just a couple millimeters. And this is an electron microscope of the tick. And look at the mouth. Look what it looks like. It looks like a drill, doesn't it? So this thing, they get into the skin and they bore and they go in a circle. Now my PA Eric says he has his own technique for taking ticks off. He says he takes a tweezer and he rotates it counterclockwise. He says that's the technique. He learned it from a doctor, a patient first, he said. But the World Health Organization says don't rotate it. The World Health Organization says grab a fine tweezers and just pull it out. And the Borrelia burgdorferi lives in the gut. So some people feel if you squeeze the tick, the Lyme disease can go into your body. So when you pull it off, don't squeeze it. So I don't know if anybody has any recommendations about taking ticks off. So here's.
I was always told to hit them with a hot pin and they pull out by themselves. They let go.
Yeah, hit them in a hot pin. When I grew up in Prince George's County, where everybody smoked, They always said put a lit cigarette to it.
Yeah.
But apparently the CDC and the World Health Organization don't encourage that. They say use a fine tweezers. So the Ixodes scapularis lives 2 years. It starts as an egg, then good morning, goes as a larvae, and then here's a nymph. So you can imagine you can't find this thing. This thing is probably like embedded in your head. There's no way you'll find it. But the adult, you can find it. So these stages are important because when the nymph gets the Borrelia burgdorferi from these animals, from small rodents. So this is the reservoir. So Borrelia burgdorferi lives in these animals. This is the reservoir and then the nymphs feed. The nymphs feed 3 times in their lives. They only have 3 meals. That's it. They have a meal when they're a larvae. They have a meal when they're a nymph, and they have a meal when they're an adult. They only eat 3 times in their lives. Can you imagine that? So when they're a nymph, they eat off these animals, and the Borrelia burgdorferi is in reservoir in these animals. That's where it comes from. Then, after it comes off of the small mammal or bird, it attaches to other animals, and we're one of those animals when it's a nymph, and it eats off of us. And then it becomes an adult, and then in an adult state, it usually lives in deer. But the deer don't get Lyme's disease. They're immune to Borrelia burgdorferi. So it's because of the deer that these tick populations continue, because they mostly feed off deer. And we have a ton of deer in Harford County. I almost hit one recently coming to work. So this is the guy who first founded Borrelia burgdorferi. And his name is Willy Bergdorfer, and he was studying Rocky Mountain fever in Montana and he's Swiss, and he found the Borrelia burgdorferi in the midgut of the tick in 1982. And these are the people that present with Lyme's disease. It's got a bimodal distribution. It's kids from ages 5 to 9, so these kids are 5, 7, 9. And then these surly adults, ages 55 to 59. What's that?
It's more bipolar, isn't it?
Bipolar? Yeah. No, Bill Cook's not bipolar. Bill Cook's a good guy. So this is not a sexual picture, but it's saliva. So why did I show a picture of saliva? It's the saliva of the tick is fundamental in the disease process because it causes an immunosuppression in our bodies that allows the Borrelia burgdorferi to grow within the skin. And it's the saliva of the tick that gives the characteristic rash of erythema migrans. So the other important thing is the tick has to be in your skin for 2 to 3 days for you to get the disease. So if you find the tick right away and pull it off immediately, you won't get Lyme's disease. The organism doesn't go into your body. So it has to be attached for 48 to 72 hours. And when it attaches in the skin, most people get a rash, the erythema migrans rash, and you get the early localized disease, which is the rash plus these things, dizziness, a headache, myalgias and arthralgias, and a fever, and it feels like you have the flu. So here's a typical expanding annular rash. Annular means ring in Latin, and it expands. And sometimes it has a centralized clearing, like here. So it looks a little bit like the bullseye. So when you get the bite, it takes a couple weeks, maybe 1 to 30 days to get the erythema migrans, and sometimes it clears. Some people don't get the rash. 10% of people never get the rash. Half adults get the rash. Most children get the rash, and it can enlarge. And you also, remember, get sick. And when do you get Lyme disease? It's in the summertime. And why is it in the summertime? That's when the ticks are out, and that's when we're out doing whatever we do. Bill Cook's out there riding his horses. That's when he gets Lyme disease, and the tick attaches to him, climbs up to his head. So it's the summertime. June, July, and August is when we contract the disease. And when you contract the disease, the early disease is, remember, the rash and the illness, like a flu. So if you, just so you know, so if you see someone in the endemic area, which is Harford County, we're endemic, If you see somebody with a rash and a fever and like the flu, that's enough to give a diagnosis of Lyme disease, and you can treat them with antibiotics. So that's kind of important. You don't need to have any testing. We'll get into that. Now, in the early disease, you can also get some pretty serious stuff, which for me is very scary. 5% of people get cardiac symptoms, and 15% get neurological symptoms. So the neurological symptoms can be any cranial nerve can be infected. So your sixth cranial nerve to your eyes can be infected, but you can get Bell's palsy, seventh cranial nerve. You can get meningitis, and these people present like they have meningitis, neck stiffness, and they have a lymphocytic meningitis. And you can also get a cardiac disease. We'll go over that in the cardiac disease in a second. In the late disease, that's when they come to the orthopedic surgeon. So when is the late disease? It's usually a couple months later when you get a synovitis. And the most common one is knee. 90% of them get into the knee. It's usually months after the exposure. And if you don't get any antibiotics at all, 60% of the people get a synovitis. So it's over half. And that's when they come to the orthopedic surgeon, or they call us from the ER, they come to the office, they have a swollen, painful knee. Usually they don't have a history of a rash, or they don't remember it at that time. It's because it's months later. It can be a couple joints, and it's usually the knee. It's asymmetric, and it's usually within 6 months. Now, is this bad to have this knee effusion? Well, the Borrelia burgdorferi does induce the chondrocytes to secrete metalloproteinases, which destroy cartilage. But it's not like staph, where staph, the bacteria of staph, Borrelia burgdorferi is a gram-negative bacteria. Staph creates proteolytic enzymes that really destroy joints. And you have a very quick destructive process. So Lyme's does secrete some enzymes that can destroy joints, but nothing like acute septic staph. So that's important for us as orthopedic surgeons, is if we have somebody with acute septic staph, we have to wash it out, especially if it's a child. Now, in the early disease, you can also have cardiac problems, 5% of people, and they can present as syncope, fatigue, shortness of breath, palpitations, so very nonspecific symptoms. And they can cause a myocarditis, a pericarditis, and they can cause AV block. And the other thing to remember is any cranial nerve can be affected.
Hey, Spiro, what
Yeah.
what are those lesions on the heart you're pointing at?
Oh, that's nothing. That's just a heart picture.
Oh.
I just put that so you guys can remember heart. Sorry about that.
I thought you were looking at those white specks.
Nah. The other thing in late disease is they can cause encephalitis and unusual memory problems, cognitive problems, and also a peripheral axonal polyneuropathy. And actually, they can cause almost anything, I think. McCool, can you say how about some cases that you've seen?
Yeah, these are very difficult to diagnose when they're in their late stages. If you're looking for neurologic disease, the most common things that you see with neurologic disease is the early disseminated phase, when you see the maybe a facial palsy with a septic nerve paralysis would be the most common thing, and then a lymphocytic meningitis. And typically they're not as toxic as a regular bacterial meningitis, where you'll have the neck stiffness and all the photophobia. They'll have maybe a facial palsy, some big, neurologic symptoms.
It's the same thing orthopedically. They're not toxic,
Exactly.
like Staph aureus.
But in the late stages, usually, they should always, to diagnose these are very difficult. A lot of times they'll coincide with normal aging, dementia, things like that, and it's very hard to diagnose. But they should always, the rule of thumb is that they should have a positive Western blot IgG, and that will, at least, you'll have some confidence that they have had a late phase of Lyme disease that may have gone untreated.
So they've been exposed. That tells you they've been exposed. And then they have this. We had a case here, inpatient, that Eric saw was a cervical brachial plexopathy, right, Eric? Yeah. And the MRI looked normal in the neck. We wanted to do surgery on the patient's neck, but the MRI was normal. So, we didn't feel right doing any surgery if the MRI is normal, and it turned out it was Lyme's disease, brachial plexopathy. Okay, so now the problem with spirochetes is they're really hard to grow. So if you grow them for 12 weeks, which is 3 months, half the time it grows out. So that's not a good way to diagnose it. So what we're saying that the testing now that's is recommended by the CDC is the two-tier test, and the first is an ELISA test, which is sensitive but not specific. And if you meet certain criteria, there's a Western blot, which is specific and not so sensitive. Now this is an antibody test, so it just tells you that you've been exposed to the disease. And this can be positive for years. So you could get Lyme disease, be successfully treated, and then 3 years later you'll still be positive in the Lyme's test for the ELISA and Western blot. So it just means your body has seen it. The other aspect, which is very important, is that if you have a child that comes through and has the rash, that child doesn't have antibodies yet because it hasn't been in the patient's body long enough to develop an antibody response. So it's kind of worthless in the acute phase. And that's why you don't need any testing to give a diagnosis of Lyme disease in the acute phase in an endemic area. Is that right, McCall? Okay.
The erythema migrans rash is diagnostic. You don't need any blood work for that.
In an endemic area,
Correct.
which is us. So the antibody response can take weeks, and this is now this is cases per 100,000. I wanted to show you because it's interesting. So it tells you again where it is, and this is in 2010. These are new results. Delaware now is number one with 73, and the entire state of Maryland is 22 per 100,000. But if you look at Maryland and Harford County, we are in a pretty big zone, but the biggest zone is on the Eastern Shore in Delaware. This is, I think this is 2009. But if you take other maps, Harford County is in a really endemic area. And if you look at our numbers from the Public Health Department of Harford County, which God knows how efficient they are, maybe they're efficient, I don't know. But they said in 2009 they had 128 cases, in 2008 162 cases. In 2009, we last time they counted, there was 242 people in our county, in Harford County. So if you take these numbers and do the math, Harford County is about 53 per 100,000. And that's just cases that are diagnosed. I mean, you can imagine, I don't think most primary care physicians never report things to the CDC. They don't have time for that. They want to go home and golf and ride their horses with Bill Cook. So our incidence is probably really high. So at 53, that puts us really up there with Connecticut, and it's probably just as high as anybody else. So we are in a very endemic area. Now there's another way to diagnose it with PCR with a synovial aspirate, and that's something that we do all the time as orthopedic surgeons. So if we aspirate the knee and send this to the laboratory for PCR, it's very sensitive and very specific for having an active infection. And this test is different from the antibody test because this is a direct test. This tests if you have the bacteria in your knee. So it's a great test to see if someone's infected. Unlike the lab test, which is an antibody test, which just shows you've been exposed. So for us, it's a really important test to send off when we have a patient with synovitis or a fusion. Is that right, Nicole?
Yeah, the PCR testing in synovial fluid is much better than PCR testing in other body fluids that we do check. It's in Lyme meningitis, PCR is almost never positive.
It's in the synovial fluid that's best, which is great for us as orthopedic surgeons because we do knee aspirates all the time. Okay, so that's kind of important. So the other thing is this has been studied with, it was a couple of years ago, a series of children that came with septic joints. And they found what are the criteria that separate Lyme disease from a septic knee when they present. So, will we have a high suspicion for Staph aureus or bacterial sepsis, or low suspicion? The kids with Lyme disease did not have a fever. The kids with Lyme disease, usually it was a knee. The kids with Lyme disease usually had normal C-reactive protein levels. And the kids with Lyme disease could walk on their joints. So in orthopedics, if a child doesn't walk on their joint, that could be a serious problem. It could be an acute skiffy that needs to be pinned. It could be bacterial infection. So for us as orthopedic surgeons, if a child won't walk, it's probably something serious. And the opposite is true too. If the child walks around, it's probably not as bad of a process. It could be JRA, it could be Lyme disease, it could be a skiffy, but it's not an acute skiffy that needs immediate pinning. And then on the aspirate, this is a review of the aspirate results in kids with Lyme disease versus a bacterial infection, Staph aureus, that needs to go to surgery. The kids are usually about 8 years old. The arthrocentesis results in Lyme's was around 60,000, and in bacterial infection, 120,000. The peripheral white count in Lyme disease was 10, and in the bacterial infection, 14. So this is higher. The serum differential was kind of similar, polys. Actually, that wasn't polys. I'm not sure what that was. The SED rate was about similar, and the C-reactive protein was much lower in Lyme's than it was in the bacterial infection. So these are ways that you can present. These are ways to prevent Lyme disease. This is for Doug's kids. Tell your kids to put their socks over their pants, and what's the chances of them doing this? Wear long sleeves that look ridiculous, and have the moms cover them with this disgusting stuff on their skin. So you can prevent the ticks from getting onto your body. And we'll go over this, but the antibiotics are doxycycline, amoxicillin, and I think cefuroxime, right, are the three basic ones.
Right.
And then the IV antibiotics are ceftriaxone, cefotaxime. So this is just from the last, this is a review, and McCool, you can change it, but if you diagnose Lyme disease, it's a 28-day course of oral doxycycline or amoxicillin. And if after that they don't get better at all, it's an IV course of ceftriaxone for a certain period of time. But if they get just slightly better after a month, you can repeat the oral antibiotic.
So a lot of times for late Lyme arthritis, I rarely will use the IVs. I mean, I'll still, most of the time, either go with 1 or 2 courses.
1 to 2 months.
Oral doxycycline, yeah.
When do you use IV? For cardiac or neuro?
The only time at this point I'm still using IVs is for meningitis. Even for cardiac, I'll still use doxycycline.
So if someone comes in with third-degree AV block, you just give them doxycycline?
Inpatient, I'll give them ceftriaxone until their heart block resolves, then I'll complete the course of doxycycline. Yeah.
Okay. So then if the patients still have persistent arthritis or synovitis, you can check their knee joint. So this is a good test now. We check their knee joint, and if it's positive, you know the bacteria is in there because it's a direct test. So those patients need more antibiotics for another month. But if it's negative, they're not infected. So if a patient has a synovitis and you aspirate the joint and the test comes back PCR negative, that's not active disease. So that's something else, which is post-antibiotic refractory Lyme's disease of the knee, which is probably something like rheumatoid arthritis. And those patients do not improve with antibiotics. In fact, the antibiotics, it's been proven that it makes you worse. Like you get other complications from antibiotics. And that's a very controversial subject because there's a lot of doctors that just keep giving antibiotics for years. Is that right, McCool? And also like massive doses too.
Yeah, I think the idea is that, and that's the rationale behind when I don't give a lot of times IV ceftriaxone, it's probably because I don't think they're going to respond. If they haven't responded to a month or another month of doxycycline, they're probably not going to respond. They're probably at that phase where it's more of an autoimmune triggered arthritis or just from the initial infection.
So what's the most, when do you call it quits for antibiotics? 3 months?
Yeah, for me, I'd probably call it quits after that. If they have recurrent joint infusions after like 2 months of antibiotic therapy.
Yeah, obviously, a joint infusion can be tested. You can aspirate it and see if it's positive or negative.
I haven't been involved in a case where I think the most I've seen is 2 joint infusions with positive PCR testing requiring subsequent months of doxycycline. I haven't seen more than that.
Okay. So there's a couple. So what? So there's also a disease called post-Lyme disease syndrome, and this is people who've had Lyme disease. They have pain, fatigue, fibromyalgia, memory problems, and that's another syndrome that patients get with Lyme disease. But this is not from active disease. So this also is some kind of autoimmune disease, and the other medicine that's been shown to be helpful for patients with synovitis. after being successfully treated with antibiotics that are PCR negative is Plaquenil. But that's more something that a rheumatologist would do. That's not something that we would do as an orthopedic surgeon. But I think the main point is that if everything's negative and you still have problems, antibiotics is not going to help anymore after 3 months. So the other thing you can do for these patients, this is for Dr. Clough so you can get some more cases in, is patients with refractory Lyme's arthritis and synovitis, is they do improve with synovectomies. So when they reviewed these cases, 80% of patients had good results long-term, 3 to 8 years. So patients with refractory synovitis from Lyme's disease do well with synovectomies.
Have you guys, I know you guys probably see a lot more of this than I do because they'll probably get referred to you first. Do you guys see often that many positive PCRs on the same patient maybe after a couple of occurrences?
I've never seen a positive PCR after treatment with antibiotics, but I'm not a general orthopedic surgeon either. I mean, when I diagnose them, then I'm sending them elsewhere for if they need surgery. How about you guys? What's your experience with Lyme disease?
I had one last month. Kind of surprised me. Guy with persistent effusions, sent him off for a rheumatoid workup, and Lyme spider came back positive. He's on doxycycline now. I don't know what long term is going to do, but I didn't even know about the PCR synovial test, frankly. It's a good lecture.
I don't think most labs do that, though, Spiro. Isn't it hard to find a lab that will do the PCR
No,
test?
we have a synovial test for Lyme disease.
Yeah.
Yeah, we have it.
Like LabCorp,
I think they do
you send
it.
it
They-
off, they're
no, they
just,
do.
We don't know what this is. Give us a
No. Put synovial fluid, rule out Lyme's disease, active infection, PCR. They'll do it.
If you just put, I think if you just put Lyme PCR on synovial fluid, they should be able to do it.
They'll do it.
that a couple times. I don't know who it is. If it was Quest or LabCorp, who it was, but it was just like they didn't know what they were doing, and they sent it for antibodies.
No, they probably thought you wanted the other test.
Well, I mean, if I have that, I'll send them the blood work, and I'll aspirate and send that off.
Yeah. The blood work's the antibody test, so ELISA
They
Western
don't
blot.
do I've had a couple times where it comes back with the antibody test on the synovial fluid.
Yeah, well, that's
The literature.
that's the whole point of us having multidisciplinary conferences. Now you know.
Yeah.
So you put it on your script. You can remember PCR, polymerase chain reaction, yeah. So then you know. I didn't know this until I did all this reading. I had no idea.
Have you seen any total joints involved with this?
No.
And would this require an exchange arthroplasty cleared, or just a month of doxycycline and maybe a washout?
I haven't even seen it require a washout. Usually just antibiotics will take care of this. And sometimes in the bad cases, like I said, you might have someone who's been treated for a month or 2 months come back a year later